This is Robert Gross. It is my pleasure to present this PowerPoint of our chapter, Electrical Stimulation for Epilepsy, on behalf of my co-authors, Dr. Neil Laxpati and Tanner McMahon. The objectives of this presentation are to help you understand the neurological networks involved in epilepsy and to identify the various targets within these networks that we use for neuromodulation, and also to understand the basis behind current clinical neuromodulatory strategies for epilepsy. Epilepsy is a tremendous problem for the world's population, with about 1% of people in the world over suffering from epilepsy, with 30 to 40% of these cases having medically refractory epilepsy after multiple medical trials. A large subset of these patients are not candidates for resective surgery, and few will respond to additional medications, so there is a great need for alternative therapies. We focus on the networks in epilepsy to help us to identify potential targets for new therapies. Focal onset seizures vary considerably in their site of onset, but appear to propagate along common neural circuits used for normal brain function. And as we understand these circuits, we can identify targets that might be those that we can neuromodulate. These pathways provide common nodes at which these tools may influence the onset and propagation of the seizures and lead to clinical benefits. Electrical stimulation of the nervous system is a promising neuromodulatory therapy, and there are others coming along that involve genetic therapies as well. Deep brain stimulation has proven to be extraordinarily effective for treating movement disorders such as Parkinson's disease, tremor, and dystonia over the last several decades, although the mechanism of action remains poorly understood. Initially, it was thought that the mechanism was inhibitory in nature, as it mimicked the effects of ablative procedures such as pallidotomy and thalamotomy. However, stimulation amplitude, frequency, and pulse width and other factors play major roles in determining the outcome of electrical stimulation. These different parameters have different effects on various nervous system structures such as axons and cell bodies. In fact, activation thresholds are lowest for myelinated axons, followed by unmyelinated axons, dendrites, and then cell bodies. And this helps us to understand how neuromodulatory therapies might work, perhaps on white matter rather than gray matter as initially expected. McIntyre et al. Suggest that the majority of neurons within 2 millimeters of an electrode will entrain efferent outputs at the stimulus frequency, whereas those stimulated at subthreshold levels will be suppressed. Thus, electrical stimulation may be overriding the neural circuit or blocking or replacing abnormal signals. Also, it could lead to synaptic depletion, which could then lead to inhibitory effects as well. Neurochemical interactions, gene and protein expression may also play a role, and indeed astrocytes can play a role that has been underappreciated. The progressive improvement that we see with all neuromodulatory treatments with time suggests more long-term neuromodulatory roles, in fact. For epilepsy, the targets that we have are based on our understanding of the networks that are involved, as well as empirical findings that we've inherited essentially over the decades. The map on the right, which is presented in greater detail in the chapter, shows some of these neural circuits that have been elucidated over the years. Initially, vagus nerve stimulation was the first neuromodulation therapy that we had available to us. This was based on certain theoretical considerations as well as empirical results. In fact, more empirically, the cerebellum was tried already back in the 1950s and 1960s without a great understanding for its role anatomically. The hippocampus has been a central area involved in epilepsy for the last 50 years or more. And this was an obvious target for researchers to begin to explore for neuromodulation. The subthalamic nucleus and substantia nigra pars reticulata were elucidated in animals, the so-called basal ganglia role in epilepsy, and presented also additional targets as especially we became familiar with subthalamic nucleus stimulation for Parkinson's disease. The centromedian nucleus of the thalamus became a target based on certain physiological considerations and was tried a number of years ago in Mexico City initially, and has been being explored in many centers across the world. The anterior nucleus of the thalamus was another area that was identified based on the limbic circuitry in epilepsy and tried back in the 1960s as well, and has become the most predominant target for neuromodulation for epilepsy. Other targets, including such as the nucleus accumbens, have also been identified based on their role in the circuitry involved. First, I'll discuss vagus nerve stimulation, the first neuromodulatory therapy that became available back in the 1990s. This was approved by the U.S. Food and Drug Administration for focal epilepsy and was subsequently CE marked. It involves the implantation of a coiled electrode that is placed around the left vagus nerve because of certain anatomical physiological considerations, although occasionally it might be done on the right side. The sensory afferents of the vagus nerve project to the nucleus of the solitary tract in the medulla, and from there broadly through the thalamus, amygdala, anterior cingulate, frontal, and parietal cortex. There were two industry-sponsored randomized double-blind clinical trials that led to the approval of vagus nerve stimulation in the 1990s. The first one, EO3, compared two stimulation paradigms in 114 patients. There was a high stimulation and a low stimulation. One of the considerations in running a clinical trial of vagus nerve stimulation is that it creates hoarseness through activation of the laryngeal nerve, and so patients know when it is on, and so it was necessary to have this slow stimulation foil during the double-blind clinical trials. There was a statistically significant reduction in the frequency of seizures with high stimulation versus low stimulation, as well as when compared with baseline, although none achieved complete seizure freedom. The second trial, the EO5 trial, similarly compared two stimulation paradigms in 196 patients, a high stimulation where stimulation was on for 30 seconds every 5 minutes, and a low stimulation where stimulation was on for 30 seconds every 3 hours. The high stimulation condition led to a 28% decrease in seizure frequency as compared to baseline, whereas the low stimulation condition led to a 14.2% decrease in seizure frequency as compared to baseline. The unblinded follow-up period demonstrated efficacy that continued to improve over time, in fact, over the next several years. Further reviews suggest VNS may achieve greater than 50% reduction in seizures in childhood epilepsy. On the basis of the EO3 trial and the EO5 trial, vagus nerve stimulation was approved by the FDA in the 1990s. It is, however, not yet approved for generalized epilepsy, although it has been remarkably effective in generalized epilepsy in retrospective trials, including for Lennox-Gastaut syndrome. There are adverse effects from vagus nerve stimulation that I already alluded to, with a voice change and hoarseness, but which is not painful, although from time to time patients might experience throat pain, coughing, dyspnea, paresthesias, muscle pain, or headache. In recent years, we've had access to a novel form of vagus nerve stimulation, which is automated based on the detection of atrial tachycardia, capitalizing on the location of the internal pulse generator over the heart in the left side of the chest. Using this automated feature that triggers additional stimulation in patients that have atrial tachycardia, 50% of newly implanted patients had a greater than 50% reduction in seizure frequency, and 71% who had the novel device replace their current device demonstrated a greater than 50% reduction as compared to their previous device. There are other forms of vagus nerve stimulation that are available as well, including non-invasive vagus nerve stimulation, although there has thus far been no clear benefit in treated groups versus controls. And in fact, there's non-invasive trigeminal nerve stimulation that has been studied of late, but a phase 2 study did not demonstrate significant differences, although there was some suggestion of meaningful effects, and we expect more studies of these non-invasive therapies to come in the coming years. The cerebellum, as I mentioned earlier, was one of the earliest targets that was electrically stimulated for epilepsy, dating back to the work in New York in the 1960s. The mechanism is unclear, although it is thought to potentially act through thalamic inhibition or stimulation via Purkinje cell outputs. Also with inhibitory projections to the zona incerta and pretectal nucleus, or perhaps through the deep cerebellar nuclei. There have been no randomized controlled trials of cerebellar stimulation, but pooled series of 115 patients have demonstrated a seizure freedom rate of 27% and a seizure reduction of 76%. These studies all suffer from small sample size, variable results, and a high complication rate, and thus cerebellar stimulation to this date is of questionable usefulness. The hippocampus, again, has been identified since the work of Penfield as being central to so-called limbic epilepsy, which comprise a majority of patients with focal impaired awareness seizures. Hippocampal resections, or of late ablations, are very effective, but may be contraindicated in some patients, especially those patients with dominant onset mesial temporal lobe epilepsy with preserved verbal memory, who might have memory at risk from a resection or ablation, patients with bilateral mesial temporal lobe epilepsy, and patients with recurrent MTLE contralateral to a prior resection. The first trial of hippocampal stimulation was from the group in Mexico City of the Velascos, using bipolar stimulation to the head of the hippocampus or the amygdalo-hippocampal junction in 9 patients, which resulted in 44% of patients becoming seizure-free at 18 months. None of these patients, interestingly, had mesial temporal sclerosis, and this group has found less benefit in patients with MTS than in patients with MRI normal hippocampus. The group of Bone et al. Had a series of 11 patients in which they noted that 6 had a greater than 90% reduction. This therapy, however, is not yet clinically approved. There have been other small series reported with some success, including the recent series of Cuquiert out of Sao Paulo, Brazil, who described the only randomized controlled double-blind study of hippocampal stimulation in MTLE, published in 2017. In this study, there were 16 patients who were assigned to active stimulation versus sham in a 1-to-1 ratio. The active group received bipolar continuous stimulation of 300 microsecond pulses at 130 hertz and titrated this up to a final intensity of 2 volts. 4 out of 8 patients became seizure-free, and 7 out of 8 had a greater than 50% seizure reduction. In contrast to the results from the Velascos, Cuquiert found that patients that had hippocampal sclerosis actually did better than those without hippocampal sclerosis. Adverse events in this study included local skin erosions successfully treated with antibiotics, but no adverse effects on memory. The subthalamic nucleus has been explored over the last few decades based on the preclinical work in animal models from several groups, including the work of Benabid and his group in Grenoble, and the work of Karen Gale and her group in Washington, D.C. at Georgetown. The animal models of limbic seizures implicated the STN as well as the substantia nigra pars reticulata in epilepsy. Benabid and Chabardez presented a small case series with promising results, with 67 to 80% seizure reduction in 3 patients with inoperable paracentral neocortical seizures. Others have noted anywhere from 33 to 80% reduction in individual patients. Vesper and colleagues demonstrated a 50% reduction in seizure severity and freedom from stimulation and seizure freedom from stimulation across the inferior subthalamic nucleus and SNR bilaterally, the inferior region being consistent with the limbic part of the STN STN. Willie et al. Reported 30 to 100% reduction in myoclonic seizure frequency from bilateral subthalamic nucleus DBS in 5 patients with progressive myoclonic epilepsy, followed in an unblinded fashion. At this stage, STN stimulation might be considered a non-FDA approved palliative option, particularly in patients with myoclonic epilepsy and other motor types of seizures. We do expect to learn more about STN in the coming years. The centromedian nucleus of the thalamus was initially suspected to be a reasonable target by the Velasco group in Mexico City based on the widespread projections to cortex and the role of the centromedian nucleus in cortical excitability. More recent understanding of the centromedian nucleus tells us that there is a substantial input of CM into the striatum, in fact, which presents another possible mechanism, especially with the understanding, as alluded to previously, of the role of the basal ganglia in certain types of epilepsy. The Velasco group again studied centromedian nucleus stimulation of the thalamus in patients with generalized epilepsy and ultimately began to focus on patients with Lennox-Gastaut syndrome, where the best results were seen, with 2 of 13 patients becoming seizure-free and 8 experiencing a 50 to 80% reduction in seizures. A small randomized sham stimulation double-blind trial done by Bob Fisher while at Johns Hopkins in the 1990s, however, failed to show a statistically significant difference in seizures in the stimulation group as compared to the control group. But this was likely due in large part to the small number of subjects and to the low stimulation amplitude that was needed to maintain blinding in that study. There have been several studies that have continued to explore the centromedian nucleus with continued good results, including that from Valentin et al., who reported 11 patients with bilateral implantation who underwent a single-blinded treatment with 3 months of sham and 3 months of therapeutic stimulation, followed by 6 months of open-label stimulation. All 6 patients with generalized epilepsy had greater than 50% reduction during the blinded phase. However, they also studied a group with bifrontal epilepsy, and only 1 of 5 of these patients had similar results. Finally, San et al. Reported a 14-patient case series which demonstrated a greater than 50% seizure reduction in all 4 patients with Lennox-Gastaut syndrome and 7 of 10 patients with multilobar epilepsy. We still have much to learn about the centromedian nucleus, including the roles of subnuclear anatomy in this target. But it continues to be a viable, albeit not yet FDA-approved target for generalized epilepsy. And now we turn to anterior nucleus of the thalamus stimulation, this target that we know the most about. The ANT anatomically is actually comprised of several distinct subnuclei with different pathways involved, but all involving the cingulate region and the hippocampus. Several small series throughout the 2000 pilot studies showed promise of ANT stimulation, following on the early work done in New York. This led to the stimulation of the anterior nucleus of the thalamus trial, or SANTE. This was a randomized controlled trial of 110 patients assigned 1-to-1 to active versus sham, with a crossover to open-label stimulation of 3 months. There were implantation effects noted in 20% of both groups. In other words, improvement before the stimulation was even turned on, or improvements in the sham stimulation group. At the end of the blinded phase, however, there was a 40% median reduction in the stimulated group, as opposed to a 14% median reduction in the non-stimulated group, for a statistically significant improvement. In the open label follow-on study, following these patients from 1 year, 2 years, and 5 years, and even longer now, median reduction was 41, 56, and 69%. However, again, only a very small number of patients become seizure-free with this therapy, with only 10% seizure-free at 5 years. The SANTE trial ultimately led to FDA approval as well as CE mark approval and approval in many nations across the world over the last decade. And thus, this therapy is now in widespread use. Side effects from anterior nucleus of thalamus stimulation include memory impairment in patients with a history of memory impairment, but which resolved with changes in parameters and time. Similarly, decreases in mood have been noted in patients with mood disturbances that also improve with time. We have come to know more about the optimal target of ANT stimulation since the SANTE trial was published, such that we now understand that the anterior superior portion of ANT in proximity to the mammillothalamic tract which is shown on the figure, is associated with superior outcomes. This is also true in the patients in the SANTE trial, which was just recently published as well. Direct target of ANT via preoperative MRI targeting the mammillothalamic tract is now a viable option and perhaps the preferred option for targeting these patients, and probably will be found to lead to improved results in the course of time. In the SANTE trial, we and others used the transventricular approach, and we continue to favor this approach because of its accuracy in attaining accurate placement within the anterior nucleus of the thalamus. However, the European group and others have explored an extraventricular and indeed posterior approaches to the same target, which don't appear to be quite as successful as the transventricular approach, but certainly further study is necessary to resolve this issue. Responsive neurostimulation is a type of stimulation that uses closed-loop automated seizure detection and stimulation of neocortical structures or the hippocampus in response to seizure detection. In this case, the internal pulse generator is implanted into a window of skull that is removed such that no wires are shown outside the patient. But in fact, the purpose for this is to decrease the noise floor by having the amplifier as close as possible to the recording electrodes. Responsive neurostimulation was subjected to a pivotal randomized controlled trial, much like the SANTE trial that was published in 2011. There were 191 patients that were, again, one-to-one assigned to active versus sham. After the randomized and blinded evaluation period of 3 months, the active group had a 41.5% reduction compared to a 9.4% reduction for the sham, which was statistically significant, and again, quite similar to the previously described SANTE results. And again, the 2-year follow-up with open-label stimulation showed further improvement with 53% seizure reduction. Again, as in the above therapies, there was a low seizure freedom rate from this therapy. The 6-year follow-up results continue to demonstrate an improvement in median seizure reduction, which now stands at around 67%. RNS has been found to be particularly useful in patients with multiple seizure onset zones that have been identified, and those with onsets in eloquent cortex, but also affords the unique ability to track seizures long-term in an ambulatory setting. Thus, for example, to be able to resolve whether patients have bihippocampal onsets or onsets that ultimately can be found to be unilateral in their natural setting. In conclusion, after nearly a half-century of study, electrical stimulation for epilepsy has been found to be useful in controlling seizures in patients with medically refractory epilepsy. This comes now in the form of vagus nerve stimulation, ANT, deep brain stimulation, and RNS. Despite these results, only a small number of patients actually become seizure-free, which is, of course, the result of all seizure and epilepsy treatment. However, most patients have a 50% reduction in seizure frequency, which is very meaningful and substantial in the setting of medical refractoriness. However, we need to look for new strategies to continue to be able to move this good therapy to a great therapy. Strategies and approaches that might improve effectiveness include better elucidation of the mechanisms of action of deep brain stimulation and RNS, technological advances, novel devices, closed-loop devices, and a better understanding of epilepsy networks and the potential of new targets to help to control epilepsy that involves these circuits. We also need to always remember that the goal is no seizures and no side effects, and we look for further improvements in the coming years. Thank you very much for your attention.